Science knows no country because knowledge belongs to humanity. A very warm and pleasant day to everyone. I'm Dr. Mansi Jain, the co convenor of SIG Endoscopy, and it gives me immense joy and I'm full of gratitude that I welcome you all today for this joint webinar organized by IFS SIG Endoscopy and IFS UK Forum on the surgical frontiers in reproductive medicine, current trends and directions. In every hidden corner, endoscopy brings light, revealing the path to hope, healing, and new beginnings. And this webinar today is very unique because it brings together the best of both worlds. We have a star studded faculty, all of whom are stalwarts and trailblazers in the field of endoscopy and infertility, both from India and UK. So, I hope this webinar will spark meaningful discussions, foster collaborations, and enhance our overall understanding of the role of endoscopy in infertility. So, without delay, I now invite Dr. Professor Kuldeep Jain, who's the mentor of SIG Endoscopy, to kindly welcome and address the gathering.
Thank you, Mansi, for inviting me here to address this really wonderful gathering. And I am really happy to see the progress made by both the groups, like IFS, SIG endoscopy, which has been doing really wonderful job. And I must congratulate the convener as well as co-convener, Dr. Parul, Dr. Deepak and Mansi for thinking of such programs, bringing the stalwarts in the field and discussing our day-to-day problem. I am more happy for IFS UK Forum because this has been our dream that we should be able to collaborate in some form. And I must congratulate Dr. Raj Mathur and Dr. Jayant Mehta and whole team for doing wonderful job. I think this is third program since we started last year. And this is actually a amalgamation of both the worlds, as Mansi said, that because the practices are different in India as well as in UK, and we keep on learning things from each other. And this platform is certainly going to provide really a lot of take-home points, which everyone who has joined today, and I think this webinar will be available online for later use also. So this is going to be really very productive exercise. And again, I welcome you, everyone, all faculty who are going to give a lot of inputs in today's program, as well as audience for joining this wonderful evening. So again, thank you very much for joining. And as mentor of IFS, founder of IFS, it is always very great feeling when such type of programs are being conducted. So thank you very much, and all the best. Thanks.
Thank you, sir. I now invite Dr. Raj Mathur. He's a well known figure. He's the current secretary of IFS UK Forum. He's also a consultant in reproductive medicine and surgery at the Manchester Foundation Trust. He is the honorary senior lecturer, University of Manchester, medical director of Manchester Fertility, and member of NICE Guidelines Committee on Fertility. So, sir, I request you to kindly address the gathering and welcome them on behalf of the IFS UK Forum.
Thank you, Dr. Mansi. Thank you, Dr. Kuldeep, all the members of the faculty. It is a great pleasure to welcome all delegates to this meeting. This is the third webinar that the IFS UK Forum have been involved in. Our forum consists of approximately 60 members. I am very glad to say it's a very active forum. I have amazing support from my co-secretary, Dr. Harish Bhandari, our treasurer, Dr. Uma Gordon, and above all, our patron, Dr. Jayant Mehta. And for them, I have a huge amount of gratitude. This is the first time that we are actually looking at a webinar that focuses on surgical aspects. And I think quite often surgery is ignored when we talk about infertility, and everything seems to revolve around IVF. But it's important to remember the role of surgery. It's important also, as Dr. Kuldeep said, practices are different between experts in different parts of the world. It's very important for us to learn from each other across jurisdictions. And for that reason, I'm especially happy that this webinar includes faculty from both the UK and from India. I'm really pleased about that. Well, I hope you have in Manchester today, it is a warm and sunny day. I hope you have good weather wherever you are. So I hope you're comfortable. I hope you're ready to learn. And also, very importantly, I hope you're all safe and we are thinking of you. So good luck with the seminar.
Thank you so much, sir. And I'm very sure all our delegates are now very excited and looking forward to the academic session. So, without any further delay, it is an honor and my privilege to invite the chairpersons for the first session. Uh, I would like to introduce and invite Dr. Gauri Devi, Madam. Madam is the director of Gauri Hospital Limited and Ridge IVF Group. She was She's also the Vice President of Fertility Preservation Society of India, past President IFS, ex-Vice President NARCHI, and she's a very well-known and an active figure in IFS. Madam, so next we have another very senior faculty member, Dr. Uma Gordon, Madam. She is the treasurer of IFS UK Forum, consultant gynecologist and subspecialist in reproductive medicine and surgery, and also the medical director of Bristol Fertility Clinic in UK. She is the past chair of BFS Andrology Special Interest Group and is also an RCOG supervisor for the subspecialist program in reproductive medicine. Madam, you are welcome. Next, we have Dr. Harish Bhandari, sir. He is the consultant in gynae and reproductive medicine at Leeds NHS Teaching Hospital Trust. He is also a medical advisory committee member and founder and consultant in reproductive medicine, GIVA Fertility Leeds. He is also an active member of the British Fertility Society. Next, we have Dr. Sureen Guman, ma'am. I hope she's here. I cannot see her. So Dr. Surveen Guman Sindhu, madam, she's also a very senior IVF specialist, senior director and head IVF and Reproductive Medicine Center at Max Group of Multi-Speciality Hospitals, Delhi and Gurgaon. She has 32 years of clinical experience, has authored several books, and she is the senior vice president of the Indian Fertility Society. So I now hand over the session to the chairpersons.
So now we have the next, the first is a lecture by Dr. Bharati Durapatel, who will be speaking on the role of the 3D ultrasound vis-a-vis hysteroscopy in RIF. Dr. Durapatel, you can share the screen. And she is a very senior person in IFS. And she was currently she is the HOD of Shri Hospital Pune. She is an IVF consultant, Nova Fertility Pune, National Vice President IFS, National Vice President Foxy 2016, and she was the past president of IMA Pune. She was ex-chairperson of Clinical Research Committee Foxy. And she is also the founder chapter secretary of Maharashtra chapter IVF. And she has got many awards. She was the Pune Woman Icon Award 2014, Foxy Star Awardee 2016, Inspiring Gynecologist of India 2018. So I am sure Dr. Bharti is going to enlighten us on 3D vis-a-vis hysteroscopy in RIF. Welcome, Dr. Bharti.
Thank you so much. Can you see my slides
It was there, but it went off.
now?
No.
It's okay now?
Yeah, it's okay. But make it full screen.
This is okay?
That's fine. That's okay.
Thank you so much, Dr. Gauri Devi. Good evening to all. And at the outset, I would like to thank the organizers, especially SIG chapter endoscopy of IFS and UK Forum, Dr. Manasi, Dr. Kuldeep Jain, and Dr. Raj, and the whole team. This was actually a dream of IFS to be associated with different countries and exchange the things with each other, the knowledge, and what we are doing, what things have been happening over there. I'm sorry for this spelling mistake, hysteroscopy. So this was actually a dream come true, especially for Dr. Kuldeep Jain and our whole IFS team. So thank you so much for this invitation. And as Dr. Raj said, the hot temperature and hot atmosphere is there, the same in India. And on the top of that, we are on the verge of war. Things have been going on very differently in India. Let's see how the things shapes up over a period of time. So we are all stick to the television and trying to understand what happens. So with this, my topic today is hysteroscopy, 3D versus hysteroscopy, especially recurrent pregnancy loss. You all know that there are two essential principles of medical practice. Number one, you need to have a definitive diagnosis as far as possible. And if you know the diagnosis, we have to see that and treat at the same time. So we start with, say, 32 years patient comes to us, married for 6 years and has undergone 6 IUI cycles. And an IVF cycle, one is failed, where she had 21 oocytes, 7 blastocysts, 1 fresh transfer, and 2 FPT cycles, and no pregnancy. So this is typically, we know that a recurrent implantation failure, whenever you have failure to achieve the clinical pregnancy after transfer of at least 3-4 good quality embryos, but still there's no consensus. But approximately, if you have this, then probably these patients we may label as a recurrent implantation failure. Now, diagnostic hysteroscopy showed in this patient, 21 year, the previous patient showed that very frank tubercles in the endometrium. When you see the sonography, 2D sonography, this was the picture. And when we did a 3D also, the picture was almost same, but we could not find the reason. And when we went for the hysteroscopy, the patient was having a tumor. Actually, unfortunately, that video is not running, but you could see that sago particles all over in the uterus. So histopathology of that endometrium, which we sent, came out endometrial tuberculosis, and we started anti-tuberculosis treatment for this patient. So being in India, especially, we have to think tuberculosis in the patient where recurrent pregnancy losses is happening. Your 3D sonography or your routine sonography is been showing nothing. So these patients needs to undergo the hysteroscopy. So hysteroscopy and histopathology is the only answer. Probably TVS may not give even a hint also in this type of patients. So we could see in this study that prevalence of unsuspected uterine cavity abnormalities diagnosed by office hysteroscopy prior to in vitro fertilization has a lot of meaning. So we know that there are unsuspected intrauterine abnormalities in asymptomatic patients. We could see that in this study was almost going failed procedure 1.2%, where there is a polyps, myomas, adhesions, septum, abnormalities, and there's no abnormalities. So in 2009, this was an observational study which involves 1,475 women with recurrent IVF failure. But they saw that 22.2% of the population had a prior sonography screening with no pathology found. And when they did a hysteroscopy on those patients, an abnormality was found in the uterus almost 36.6% of the cases. 16.7% was endometrial polyp, although they were very small polyps. 12.5% was endometrial adhesions. This absolutely cannot be seen very, very carefully. If you see 3D sonography, then sometimes you see, but flimsy adhesions or the adhesions absolutely in the near cornea cannot be seen. 1.5% endocervical adhesions. Endometritis was 4.3. 0.9% uterine septum, which is actually now with 3D very less likely, and 0.8% submucous fibroids. So another area where you cannot actually pinpoint on 3D sonography is endometrial micropolyps. And when you see patients with in the hysteroscopy, the presence of micropolyps at fluid hysteroscopy is associated with high probability of chronic endometritis, which is a very common, especially we see in India, chronic endometritis. And it is characterized by the presence of areas of red endometrium flushed with the white central point, like this. You see the red spot area with the white flushed line. And this is typically seen in the hysteroscopy, but 3D sonography very less likely to pinpoint the micropolyposis. It has been seen just that 120 women underwent the hysteroscopy, and we could see that the micropolyps at hysteroscopy could be seen in 14.4% patients, premenopausal AUD patients, and infertility 24.4%. So it is quite high in an infertility group of patients. And in other patients, you see it's a less, but then infertility patient is being a quite high incidence could be seen in the hysteroscopy. So it's a pathology too difficult to identify, and it is not detectable even in 2D sonography or 3D sonography. Detection is easy when saline is used for distension. Suppose if you need 2D or 3D and you are having saline infusion, probably you could see that micropolyps may float. But if they are very small, tiny, and very near the cornea, it is very difficult to identify in 3D sonography or 2D sonography also. But in hysteroscopy, it's quite likely and very easy to identify them. The prevalence of micropolyps in overall population is 11.7%, but this was 2.1-fold greater in the women undergoing hysteroscopy due to infertility. So especially we have to look into hysteroscopy very properly, and if you see, things would be very quite clear if the patient has a chronic endometritis, and you have to treat the patient, and probably her recurrent pregnancy, implantation failure could be solved. So effectiveness of hysteroscopy versus transvaginal sonography in diagnosing intrauterine lesions, especially this was in 2008 study. 938 infertile women underwent transvaginal sonography and office hysteroscopy procedure without anesthesia. This was because we all used to say that transvaginal sonography is easier and no anesthesia required, so it can be office based. So if you start comparing them with office hysteroscopy, what happens? So they did endometrial eye-guided biopsy was performed to confirm any visual diagnosis and sent for histopathology. So this is a vaginoscopic approach. 5 mm continuous flow operative office hysteroscope was used. No analgesia, no local anesthesia, and no cervical dilatation is required. and uterine cavity was distended by normal saline, and optimum uterine cavity distension was there. What was their finding is that hysteroscopy failed in two patients. Normal cavity was 587 patients, and histology also came normal in 580 patients. When there was 206 patients who had a polyps, and histopathology also confirmed it was 20. 191 patients had transvaginal sonography polyp, and I think they were because the sonographically missed polyps could be picked up by the hysteroscopy. Submucous fibroid again same, and atrophic endometrium was in 15 patients, and all could be seen in sonography also and in histology also. And thick endometrium again was 6 patients. So statistically, if you see that sensitivity of hysteroscopy in this study was 84% versus in transvaginal sonography 78%. Probably if it would have been because they had done 2D sonography, if it would have been a 3D sonography, probably this sensitivity would have been little more. Specificity was 150. This was almost good. And for positive predictive value for hysteroscopy was 88% and 78 in sonography. And negative predictive value was 148 and 152 in sonography. So sonography is the standard method of uterine cavity assessment. It enables guided biopsy. Removal of pathology like polyp adhesions can be organized at the same time. It suppose you have a diagnosis in the hand prior, and it shows 100% sensitivity and specificity in comparison with histology. So what is the diagnostic accuracy in recurrent implantation failure? If you look at 3D sonography, the accuracy is 84.1% in especially for uterine cavity abnormalities. Sensitivity is 68.2% and specificity is 91.5%. It's excellent for congenital anomalies, especially septed uterus. It's 100% accuracy. Misses small polyps on the sonography because the sensitivity goes to 61.1%. And in hysteroscopy, it detects 31.8% to 50% abnormalities in RIF patients. It is superior for especially polyps, adhesions, chronic endometritis. And this is actually the evidence, which is, I think, Royal College of Obstetricians and Gynecologists guidelines that hysteroscopy should be carried out to exclude any intra-cavity uterine pathology, and it has been shown to improve the outcome. So if you see the therapeutic role, 3D sonography has absolutely limited role. Primarily, it is diagnostic. No therapeutic capabilities are there when you only do 3D sonography, especially in RIF. But it guides surgical planning. If suppose you know there is a septum is there, you can guide. It can guide you how do you surgically plan that patient. But if you do hysteroscopy, therapeutic procedures can be done at the same sitting, say polypectomy, myomectomy, depending on how much big is the myoma, adhesiolysis, septum resection. It improves the pregnancy rate post-correction. It is almost 39.4% versus 20%. Endometrial scratching may enhance implantation, if at all you believe in the endometrial scratching. And this is the evidence which says that it gives a higher live birth rates in these patients. If we do a comparative studies of this 2016, 20, and 26, that is a trophy trial, they said that routine hysteroscopy in RIF with normal ultrasound, there's no significant improvement in the live birth rate. But if there is a pathology or there is a suspicion on your 3D sonography, hysteroscopy is definitely needed and it has its place. But routine hysteroscopy could be now replaced by 3D sonography for diagnosis. Hysteroscopy is 100% accuracy for polyps and adhesions. and it is a gold standard, especially if it is detected the pathology inside the uterine cavity. If we look at the cost, safety, and accessibility, 3D sonography surely lower cost, widely available, no anesthesia, especially in India. Like, I don't know about UK, how second opinion, you can have another look at the patient. So that all is possibility with 3D sonography. Hysteroscopy, higher cost surely requires outpatient setup, especially OT, even if you're doing the OPD basis, still it requires a little bit of setup with that all equipments and everything. Complication is very less, 2.5% perforation and infection. But I think with office hysteroscope, this is very, very minimal. So 3D sonography is preferred for initial assessment, and a hysteroscopy is reserved for confirmation or any therapy if you want to do with that patient. So clinical recommendations are initial screening with 3D sonography for non-invasive assessment of uterine cavity, confirmatory or therapeutic hysteroscopy for RIF with the patient suspected or confirmed abnormalities is recommended. Selective use to avoid routine hysteroscopy in normal ultrasound cases, especially, and combined approach 3D sonography plus hysteroscopy maximize definitely the diagnostic accuracy and IVF success rate. So this is the comparison, like invasiveness, it is non-invasive, it is invasive. Diagnostic accuracy is very high, but then less than hysteroscopy. And hysteroscopy definitely is, but it is all operative. It's patient, doctor to doctor, and the performer is very, very important, both the side, even 3D sonography also and hysteroscopy also. Treatment ability definitely in the hysteroscopy it is there, and the cost is definitely higher, and it is office procedure, but it can be office hysteroscopy also in the hysteroscopy. So to conclude, 3D sonography is non-invasive, cost-effective, high accuracy for congenital anomalies, limited for subtle lesions. Hysteroscopy, gold standard for diagnosis, mainly the therapy, and which improves the outcome in RIF. And use 3D sonography as a first line, reserve hysteroscopy for targeted intervention, and we still require larger RCTs to clarify whether routine office hysteroscopy can be benefited in RIF. So with this, thank you so much.
Thank you, Dr. Bharti, for a very elaborate illustration of hysteroscopy, comparing it with 3D. But there are certain things I would say about 3D to assess the endometrium. Whether, we can assess the volume of the endometrium. They say when we do the transfers, if the volume is a certain level, your success rate is better. So assess the volume of the endometrium, the endometrial blood flow. I would say 3D comes a long way. Hysteroscopy is not going to help. Yes, as you rightly said, hysteroscopy will give a better visualization. But by doing it 3D, 4D, we know these are some of the problems we face. We can plan our surgery accordingly. We find a submucous fibroid, we can tell the patient, look, this will be operative hysteroscopy, we are going ahead with that. But assessing the endometrium, I would say 3D, 4D is better. So also when we are doing the embryo transfer, to optimize the transfer, we will require a 3D or a 2D.
Yeah.
So
The recurrent implantation failure.
Yeah. In recurrent, what I'm telling is when you are doing, we will give her the best, no? So when we are doing it, we would like to optimize the transfer also. And also the recurrent implantation failure, where the endometrial flow is okay. That also we can't assess with the hysteroscopy. We will need to see with a 3D.
They're complementary to each other. They're complementary to each
Yes,
other.
yes.
It has got
Thank you. It was a very nice lecture, Dr. Bharti. Dr. Uma, any comments from you?
No, really enjoyed that, Bharti. Thank you so much. Presented evidence there, almost convincing us that hysteroscopy is better, maybe with recurrent implantation failures where maybe we need to do the very best. You kind of showed that hysteroscopy probably has an edge over 3D ultrasound, especially if it's a retroverted uterus or we may not get a good volume definition. Can I just can I just ask a question as well? You said think endometriosis, right? For Indian patients, I mean, we hardly think of that here, of course, in UK. Never come across. Our knowledge is very limited. But when you say think endometriosis, do you then routinely do something like CB-NAT or something before you take your patients for IVF? You don't. It's not advocated when you say.
No, it is not
Is that
advocated.
because of the cost or is it?
No, but the diagnostic accuracy is not that great, even if you do that also, because it's a polyvacillary. When to give, how much the volume, and how it is going to come out with the reports, it becomes going to be very difficult for the patient to accept that. And antituberculous treatment as such is not so straightforward, and uh, it is cost effective. It has got its own side effects. So routine antitubercular or endometrial biopsy to be sent for the TB PCR, we don't do that unless there is some reason for the patient. Like
Yeah.
patient has a past history of abdominal tuberculosis. Patients consistently thin endometrium. Whatever you do, it is a thin endometrium, or she has a repeated implantation failure. Those only patients we will go ahead and do the routinely hysteroscopy guided biopsy or biopsy as such, or the immunohistochemistry. All those things together we do.
Because the clinic that I'm linked with in India, they do the CB-NAT, but they use the menstrual endometrium. So they're not doing hysteroscopy biopsy. They're using the menstrual endometrium, get the patient in when they're bleeding, send off the menstrual endometrium, and they have picked up a few cases. So I was very interested in that, and not actually doing a hysteroscopy biopsy, but doing it with the menstrual endometrium.
You don't do actually what happens in India also. There are regions where the prevalence is very high, especially where I stay, the Maharashtra side. We have a very less prevalence. We could see that suppose Gauri Devi or Kuldeep may say north is actually a very high prevalence. Probably they have in the routinely they do, and we have seen our own data from Maharashtra. We have very less prevalence than north side. So we don't do routinely here menstrual.
Okay,
And one
thank
more
you.
thing, Dr. Bharti, if we use the menstruating endometrium, that's actually a shed and not the healthy sort of a thing, no, which come out. I don't know how much you can detect a cox in it or a bacteria in it. I think a biopsy with a gene expert or something will be a better bet.
Yeah, menstrual endometrium is not a very
Ideal
good,
thing.
ideal thing. If you are really suspecting and you want to rule out tuberculosis, then it is better to go for a planned biopsy and send it for all three things: histopathology, PCR, as well as the culture. And then you may be able to detect more cases or exclude more cases, because
Yeah,
false
I think
positive and false negative needs to be kept in mind. And
yeah.
so I think menstrual blood is not anymore is recommended actually for the
I see.
testing.
They seem to be doing it as a screening thing, and they seem to have picked up a few, which then they followed up. But it's very interesting.
Yeah.
So thank you.
Dr. Harish Bandari, any comment from your side?
Sir, you need to unmute yourself, sir. Yes.
Can you hear me now?
Yeah.
Yeah. That's better.
Okay. Thank you, Dr. Gauri Devi, madam. And Bharti, madam, thank you so much. It was a wonderful presentation. And thank you for highlighting that recurrent implantation failure is not a simple condition. It's a very complex condition. So many things we still don't know. We still don't have the consensus on the definition of recurrent implantation failure itself, leave alone looking into possible reasons for recurrent implantation failure. We published the British Fertility Society Practice and Policy Guidelines in 2022 on recurrent implantation failure. When we did the work, it was not easy because of various reasons, as you highlighted in your presentation. Mostly, there's lack of evidence around recurrent implantation failure. There is evidence about certain practices for IVF infertility, but not much for recurrent implantation failure. And you rightly highlighted that we need to be doing more randomized control trials around these things, some of these common problems that we face for some of these patients. And I feel India is the best place. You have the volume there, and you have the youth like Dr. Mansi, who will be able to kind of, conduct these studies. And as IFS UK Forum, we will always be kind of, happy to collaborate with you with anything that you want to do. Yeah.
Thank you, sir. Most definitely. Yes, madam, you were saying something, Gauri ma'am.
Do we take questions from the audience? I can't see anyone writing anything there.
So as of now, we have no questions, but I would like to urge the our delegates to get actively involved. It's not every day where you get a galaxy of these stalwarts and you get to interact with them one on one. So I would encourage everybody to grab the opportunity and ask away. And we really like a very active house and lots of healthy discussion. So, ma'am, as of now, there are no questions. So, if you give me the permission, maybe we can proceed further.
Yeah.
Thank you, Dr.
Thank you, Dr. Bharti, for a wonderful lecture.
Thank you. Thank you.
Thank you, Bharti, ma'am, for your for sharing your knowledge and experience with us today. It was truly an engaging and an enlightening presentation. Thank you so much, ma'am. With that, we move on to our next segment for today, the much awaited panel discussion. So now we move into the more, clinically challenging scenarios as far as the practice of endoscopy in infertility is concerned. We have a star-studded galaxy of panelists today who will be sharing their expertise and experience with us today and exploring the latest advancements and the best practices for endoscopy in infertility. So, the panel will be moderated by Dr. Professor Kuldeep Jain. Himanshu, I request you to kindly put up the CVs as we speak. Dr. Professor Kuldeep Jain, he'll be moderating the panel today. He's director of KJ IVF and Laparoscopy Center at Delhi and Faridabad. He is also the founder, secretary, and past president of IFS, vice president, International Society of Reproductive Surgery, and the chairperson, International Exchange Committee, IFS. Sir, I welcome you and I request you to kindly introduce our panelist.
Thank you, Mansi, for your kind introduction. Today we are going to discuss the really challenging scenario. It will be a case-based discussion, and I am really happy to see the panelists which you have given to me. They are really the stalwarts in their field, and I am sure that as we move ahead in the panel, we are going to have very interactive discussion. As I have already highlighted that the practices are different in both the countries, and there will be a lot of debatable points, and that is the idea behind this panel, that in spite of the debates and controversies, at the end of each case, we are looking that we reach to a conclusion and consensus statement, which will really help the audience to get in practice these points. So I will invite my panelist, Dr. Abha Majumdar. She is senior, I think, very senior consultant in IVF field, uh, almost 40 years of experience, 40 plus years of experience. She is also the past president of Indian Fertility Society. You can see her biodata. I am not going into the detail, but I must say that she is one of the very best orator available in India, and having a lot of clinical experience in the field of reproductive medicine. So I welcome you, Professor Abha.
Thank you, Kuldeep, for the good introduction. And Kuldeep has been a very good friend, so always the introduction is a very nice one. Thank you very much.
Thank you, thank you, thank you for being here. Next panelist is Dr. Nicholas Sampras. He is a consultant gynecologist, Department of Reproductive Medicine,
जैसा पंखा
Victoria
चला देगा
Hospital. Honorary senior lecturer at University of Manchester, UK. I welcome you, Dr. Nicholas, and I am looking forward to your input in all the cases. My next panelist is Dr. Rima Rajkohawa. She is again, can I have the CV of Dr. Rima? Yeah. She is a highly experienced consultant gynecologist, and she is having 25 years of experience in reproductive medicine. Currently, she is the program director for subspecialty training in reproductive medicine and surgery in West Midlands, and previously member of RCOG committee. So I welcome you, Dr. Rima. Next panelist is Dr. Kanan Jayaprakashan. Welcome, Dr. Kanan. He is honorary professor at University of Nottingham, subspecialist in reproductive medicine and surgery, consultant gynecologist, and IVF consultant at Care Fertility, Nottingham. So we are going to have a very exciting panel. As you can see, the panelists are they are really very experienced panel. Next is Dr. Parul Kotadwala. In India, everybody knows, and he is again a international figure. He has been chair of ICOG, and Dr. Parul is here. Mansi, has he joined?
Sir had joined. Let me just
Okay,
give
so
him a call. He
and
had joined.
he is the convener of SIG endoscopy. He is currently practicing at uh, Sai Institute of Medical Science, Ahmedabad. So welcome, Dr. Parul. And next is Dr. Sweta Mittal. She is again a senior consultant at Sir Gangaram Hospital, and I introduced her as current General Secretary of Indian Fertility Society. So once I am going to start panel, and I expect the question needs to be answered by everyone. I will take opinion of everyone on these questions. So can I share my slides? Can you see my slides? Can you see my slides?
Yes, yes.
Okay. Okay. So as we have been talking, the previous lecture has already highlighted the importance of endometrial cavity in infertility and especially in RIF. And what we are looking is selecting right seed for the right soil. That is very important. So my first question is open to everyone. I will like to take the opinion of house, so we reach to a consensus. How do you evaluate endometrium in your practice? This is because the practice may be different in India and UK, and within country also it is the individual choice. So I really want to ask, starting from Dr. Ava, how do you evaluate endometrium in your practice routinely?
Normally, it is a 2D real-time ultrasound, which I like to do in the mid-cycle, apart from day 2 or 3 of the cycle, to see that the shedding is complete, and in the mid-cycle to see the characteristic, the thickness, and that is all. If I have any doubts about the endometrium, then I go for a 3D ultrasound. Again, mid-cycle single ultrasound gives us a good idea about the whole endometrial cavity, the endometrial vasculature, and the nature. When you ask a question, is hysteroscopy superior to ultrasound in endometrial evaluation? I think in one way hysteroscopy is superior, that if ultrasound misses an intracavitary problem, hysteroscopy will pick it up. But otherwise, hysteroscopy doesn't see the vascularity, doesn't see the nature of the endometrium, and hence ultrasound is my first evaluation, a 2D followed by a 3D if need arises, and hysteroscopy if there have been IVF failures, or if I suspect something inside the cavity. And sometimes when I don't suspect anything and the patient has had IVF failures, maybe after 2 failures at my own center, I might put in a hysteroscope to see if something is being missed.
Excellent. So I think she has made the thing very clear for the audience what she is doing in her practice. But Dr. Abha, do you routinely go for 3D, or just in those cases where you are suspecting any abnormality in 2D, then only you advise 3D, or it is your routine practice to go for
No,
3D in all?
I clarified very clearly that 2D real time is my routine practice. If I have a problem in that, then in that case, I go for a 3D. 3D is not for all patients. Only when patients come with doubts or I have a doubt, then I do a 3D.
Okay, thank you. Dr. Nicholas, what is your practice in UK, and in your current practice, how do you go about evaluating endometrium?
Thank you so much, first of all, for the kind invitation today. I hope you are all well, and you are all safe. The routine practice is 2D scan for all patients, especially in the public sector where the 3D scan is not widely available. However, it depends on the availability. In some private clinics, a 3D scan can be done the same time with a 2D scan without an extra cost or effort. So 2D scan for all, 3D scan where needed, but if the 3D scan is there, we can do it the same time.
Okay.
Now on
And,
the question,
yeah,
sorry.
please continue.
Now the hysteroscopy we do reserve it for patients who have a finding in the ultrasound scan, and we do discuss it when there is recurrent implantation failure. As very well discussed in the presentation, there is no consensus how we define recurrent implantation failure, but usually when they have 2 or 3 embryo transfers with good quality embryos, after that we do discuss the option of hysteroscopy.
Okay, so before going IVF, if everything is okay on your 2D scan, then routinely you are not advising hysteroscopy. So that is what you want to say?
That's correct, yes.
Yeah.
Thank you.
Okay, thank you. Dr. Rima, is your practice different what already said by previous 2 panelists? Are you having any difference in your practice, or it is same?
I would agree with both of the previous speakers.
Yeah.
So, but because I currently work in a private sector after leaving the NHS, we are fortunate that we have a 3D scanner available. So every patient pre-treatment will have a 3D scan because it will pick up uterine cavity malformations. And then if there is any abnormality seen in the scan, then we recommend a hysteroscopy. For example, if the endometrium is very thin, mid-cycle, with a history of previous surgical evacuation for miscarriage, then we will recommend a hysteroscopy. So very much like what the previous two speakers have said, just a 3D or a 2D scan if 3D is not available for a pre-treatment assessment of the uterine cavity and endometrium.
So have you analyzed your practice of 2D findings and 3D findings? Is there any difference of agreement when you compare the finding between 2D and 3D, or almost they are same? But
Almost similar, but there is a small proportion of patients where we do pick up things like a septum, if particularly a partial septum. And that depends whether you need to do anything about it or not is debatable, because I know Jay is here today, and Jay will be able to give us his he's the expert in this field. But certainly in some cases, we will find abnormalities which are more specific in a 3D scan. So if I have a 3D scanner, I would prefer it to a 2D.
Dr. Jaya, what is your opinion, so we can move further?
No, thank you. Thank you for inviting the whole team. No, I agree with Rima and Nikos and other speakers as well with regard to the scan is the sort of first line in terms of assessing the endometrium. And as Rima said, in my practice as well, even in the NHS as well, we are fortunate to have a 3D machine. So if we are doing any IVF treatment, then we always do a 3D. Because if you have got a facility for 3D, then I would recommend doing a 3D for all. I know probably in Indian sector, it might be probably the cost for the patient. I'm not sure. But the 3D and 2D doesn't differ too much in terms of the skill set or in terms of getting the image quality. What we do is, in my practice, what we do is anybody who's coming into a fertility unit will have a scan using a 3D probe, and we take a 3D sweep of the uterus, and that the 3D can be an offline real-time 2D where we just scroll through the buttons and then do the scan, in a longitudinal plane and a transverse plane. And in addition, we will get a coronal plane. And as Rima said, we will be picking up some septums or some other subtle uterine abnormalities. And in fact, even there are, for example, like if there is a fibroid or polyp, it might help in terms of making a plan in terms of operative interventions. So for example, whether it's more of a the uterine angle which is located, or the anterior wall or posterior wall, or if it's a polyp with a pedicle, or it's a sessile. So there's some advantages with that 3D. That is only if we've got the facility for the 3D 3D probe. And same thing that we do with the ovaries as well. I know it is not for the endometrial. You asked specifically for the endometrial evaluation, but this is something that we have always been doing, taking a 3D volume of the ovary as well. So at the same time, we can evaluate the androgen follicle count and assessment and things like that. So we scroll through. So we always do a 3D. Anybody who is coming for the IVF, that is in our unit. But in a general practice, those who are coming into the fertility unit, then that is done in the general NHS clinic where they will have a 2D scan. And we will consider doing a hysteroscopy, as previous speakers said, only if there is any suspicion in terms of endometrial pathology, then we do a hysteroscopy. And we do have an outpatient hysteroscopy as well. So it is easy to access the hysteroscopy in our practice.
Okay, thank you. Dr. Sweta, Dr. Parul, anything different you would like to add, whatever is said? Otherwise, we
So
move.
I think, in our practice, the first scan is a 2D scan, and 3D scan is specific when you are suspecting mostly uterine anomalies or uterine pathologies.
Yeah.
So,
And Dr. Kuldeep,
if it
to
comes
add
to ovarian,
to Dr. Shweta, we talk about general infertility patients, we always do a 2D. We don't jump on a 3D unless we suspect something or the patient has had is going to have IVF or maybe had IVF failure, then to assess the uterus, uterine cavity, endometrium better, we resort to a 3D. We don't do it for all IVF patients.
Okay, so basically, I think there is a consensus that primary scan needs to be a good 2D scan, and if there is any suspicion or any doubt, then of course it is always better to have a 3D assessment to complement the findings of 2D. And it is not many times you find a difference, but when you compare the data. There may be little gain when you are using 3D, but not in all cases. So you really need to standardize your practice. It is not like that 3D, if you are not having a 3D, you cannot manage your cases. But certainly in some of the patients where you are in doubt in delineating, especially the small fibroids, or whether they are impinging in the cavity or they are coming in the cavity, whether you need to do an intervention by hysteroscopy. In those cases, certainly 3D might be a better tool to delineate. This is our experience. When it comes to hysteroscopy, again, they are the uh, uh, when you compare all three, the grayscale and hysteroscopy 60% agreement. 3D, if you are combining, then almost 80% agreement. But clinically, the findings may not be same when you are putting the hysteroscope. So that's why even if you are having a good 3D, many times you may miss a few subtle findings. And these are the patients where you may need to go for hysteroscopy. Now you need to decide when you need to do the hysteroscopy. And I think the house is open for that question. We may not take up, but certainly there will be one point in your practice that you will need to use hysteroscope in these patients. Maybe it is one failure or two failure, that might be different, as we have already discussed. So we move on to this is some of the guidelines which are available. I will not go into the detail. They are available, but they always say that hysteroscopy combined with 3D vaginal ultrasound provides the most accurate assessment of uterine cavity. This is 2018 ASRM exchange session. So you need to complement your tools in your practice. It is not choosing between one or either other one, but if you are having the tools, then you need to use them wisely. Now moving on to the case one, she is 28-year, married for 4 years, no conception, scanty periods for 2 years. There is no other complaint. No history of tuberculosis. Semen is normal. She has received 3 cycles of ovulation induction. What next? Dr. Jayaprakash, can you take this question for me? You have to unmute. You have to unmute.
Yeah, I would like to take the approach as a sort of a four aspects. So obviously looking at the uterus, looking at the egg, looking at the sperm, and looking at the fallopian tubes. So here I have the information in terms of sperm. I assume she has got regular periods, and obviously that
Yeah, she is ovulating. Yeah.
She's regular period. So,
yeah.
And the progesterone is ovulatory.
Yeah, she is ovulatory.
So the sperm and the egg factors are there. And then looking at the uterus, so obviously there is some indication that she's got a scanty periods for 2 years. I assume she hasn't had any intrauterine procedures. So I would rely on the ultrasound scan, particularly as Abha madam said previously, that I would like to do a scan in the follicular phase to evaluate the endometrial thickness and endometrial pattern, see whether there is any indication of thin endometrium, and of course that I will get something from the history, whether she has had any intrauterine infections or intrauterine procedure, intrauterine surgery. Then the next thing is that at the same time that we always evaluate the fallopian tubes as well. That is in our practice. So I would request
how normally routinely you are doing that in your practice?
in my regular NHS practice, we always rely on the hysterosalpingogram.
Okay, so
there are some
this is the hysterosalpingogram of this patient.
okay, so that sure. So that shows there is some intrauterine filling defects. So although the fallopian tubes seem to be patent, so the next step would be, because we are suspecting intrauterine adhesion, so the next step would be a hysteroscopy. And as Madam previously said, it is the gold standard in terms of evaluating the uterine cavity. So we'll do a hysteroscopy to evaluate this and then adhesiolysis.
Okay. So do you offer hysteroscopy in all cases or in selected cases? Again, the same point, but here you have seen. So what is the point where you will put the hysteroscope? Can you again elaborate?
So as I said to you, in our practice, we do have an outpatient hysteroscopy. So generally, we do discuss with them with regard to the outpatient versus inpatient. And we have a good service in terms of the outpatient hysteroscopy, which has got a longer waiting time in the NHS context. It's only a few weeks compared to a few months. So therefore, majority of them prefer to go with that. And there is a possibility that if we are not coming across, if the adhesions are very minimal and thin, then we will be able to sort it out during the outpatient hysteroscopy. But if it is thick, then we may have to resort to an inpatient procedure. And one thing that I would tend to do is, if it is a minimal hysteroscopy, then again minimal adhesions, then again the hysteroscopy itself might be able to release those adhesions.
Like in this patient, you are having the picture like this. So you will be taking this as a diagnostic again, or the operative one, which you will be like.
Okay, sure. This is likely needing an operative intervention.
Yes. Any other panelist?
I have a
like to
question
add?
here, Kuldeep.
Huh.
You said you've ruled out tuberculosis and she's not had any intrauterine operative procedure in the past, no miscarriage. How do you think these adhesions may have come up?
This is I think the question for panelists.
No,
Can
you just tell me
Yeah.
that could it be just air bubbles and a poorly done HSG?
They don't seem to be like air bubble because they are irregular. Can you see the irregularity? If you really see here, the air bubble are usually the round the bubble,
Yes, I
round filling
agree.
defect.
I
They are
agree.
not
They are not
air bubbles. They are not
correct.
air bubbles. Yes.
So how do the adhesions come up unless there is infection, foreign body?
Certainly,
or
there
abortion or
there may be. It is not only tuberculosis which is causing intrauterine adhesions. There may be other types of infections like chlamydia, mycoplasma, and others,
I've never seen.
which can cause the adhesions. But certainly, it is not only tuberculosis which can cause this type of adhesions.
What?
If there's no history of any intrauterine manipulation, then only thing I can say is severe PID in some form might have caused. See here again, if you see, it is not a free spill. It is restricted spill on both sides. So
Right
probably
is
this
printed,
patient.
left is restricted. But as a moderator, I would want to ask you, because these are not round filling defects which
Yeah.
rule out air bubbles. This is not, you already said that you all evaluated her for tuberculosis and there was no tuberculosis. You land up with a HSG like this and you think there are flimsy intrauterine adhesions. Something has to have caused it.
Say ruling out tuberculosis again a very difficult thing. Patient may be having coughs, but how you rule out that will depend on if you are the pickup rate on histopathology is very, very poor. So then comes the AFB and culture. Again, you don't get the very high pickup rate, but the patient is having these type of infection, this type of adhesion. So these are one of the findings which are taken as sign of tuberculosis. If there is nothing,
A
yeah.
laparoscopy should be a very
So,
intervention, first to diagnose with certainty and give her treatment appropriate, and then consider any infertility treatment for her.
yeah, so the next step is putting a scope, hysteroscope as well as laparoscope,
Yes.
and yeah, so and correcting the defect as well as sending the material for further diagnosis. So that is what I want to highlight here, that it is not necessary that whatever test you have done is so, because this is one of the clinical sign or laboratory sign which needs to be included into the diagnosis of tuberculosis. So, does hysteroscopy improves chances of conception? What is your opinion, Dr. Sweta?
Sir, in this particular case, if we look at history, if HSG wasn't available, then I would have just looked at mid-cycle endometrium during the ovulation induction cycles,
Correct.
because she
Yeah.
history of ovulation induction. Now, since the HSG is available, and if these are true intrauterine adhesions, then it's a very severe grade of Asherman's what she's having. The
Yeah.
whole cavity is full of, and there could be a very poor prognosis if there are thick bands, if there are completely tubular cavity. One sitting may not be enough. After one sitting, she may have to go on, estrogen therapy. She might need even a second hysteroscopy and sometimes even a third. So I personally feel that depends upon what is the level of Asherman. And one more consent, when I'm doing this procedure, I will also take it for laparoscopic guidance, not only to look at PID, whether it is tubercular or non-tubercular, but if inadvertently there is a
अभी time लगेगा आधा
and
घंटा
perforation and it needs a consent air. So
आधा घंटा
those are the few things what I would do. And this case needs to be dealt in with a surgeon, I mean a gynecological surgeon who is an expert in dealing with Asherman's. I think novice or people in early practices should not be dealing with these cases.
Okay, so anyone else will like to add anything for this case? Because this patient will require intervention in the form of hysteroscopy as well as laparoscopy, and then from there move on to the assessment of damage and the prognostication. So we move on.
So I think
Yeah,
going and using hysteroscopic scissors would be the best and trying to avoid any energy source.
yeah, that is
And
correct.
working slowly from lower cavity to the upper cavity. That is how I would go.
Okay,
Can
so
I just confirm,
yeah, Dr. Uma, yeah.
Jane? So this was not, I mean, it looks like, as you say, severe adhesions. Did the 2D scanning not show irregularity of the lining? Was it very distinct, very clear lining? Did it not show irregularity?
There was irregularity, but see, in the previous induction, she got from outside, but when we evaluated, there was the irregularity, and that is one thing which needs to be done in all cases, like looking very closely, and you will find something on 2D ultrasound when you are doing the monitoring in these cases.
Indeed, indeed.
Certainly,
And
yeah, yes.
yeah, and then you said the ovulation induction was done outside, because
Yeah,
normally everybody has got regular periods. Here in UK, we wouldn't do ovulation induction, but maybe so you said it was done
yeah,
outside.
I think that, yeah, that is again we are not discussing here because the management will differ from places to places, like, and we are just focusing on the some important aspect of in relation to endoscopy, use of endoscopy. So I'm just
Okay.
skipping that discussion. Otherwise, we may not be able to cover more cases. So
Yeah.
this is
Thank
the
you.
second case. 28 years, again scanty period, diagnosed as genital tuberculosis and blocked tubes during workup. Now, irregular and patchy proliferation during evaluation was seen in this case, and she was diagnosed as Esserman grade 4 on hysteroscopy with 30% of endometrial cavity available. Now, what will be your plan? How will you counsel this patient? This question I will like to ask from both side, UK panelists as well as the Indian panelists. So, um, uh, Dr. Rima, you can start on this patient, and then we move on to Dr. Ava and Dr. Sweta.
So, first of all, thank you. It's a very interesting patient. We do not see tuberculosis in our practice routinely, but if I take it from a practical point of view, somebody who's got blocked tubes due to tuberculosis and has Asherman seen on hysteroscopy, first and foremost, my focus will be on making sure her general health is treated. So the tuberculosis has to be treated and has to be the primary focus. She's young, she's only 28, and my complete focus, advice to this patient would be that get your tuberculosis treated first. Then we look at reproduction. And when we look at reproduction, because we know she's an Asherman syndrome, I would have expected that the surgeon at the time of dividing the adhesions would have considered putting some kind of a device inside the uterine cavity to try and prevent the adhesions from reforming, or at least reducing the risk. Nothing can be absolutely confirmed, but at least to reduce the risk. And I think that, in fact, in another group, we were discussing as to what is the best kind of device to place in the uterine cavity. I think that most of us do use a copper device or a plastic device inside the cavity. The next thing is that while she's simultaneously completing, I think the anti-tubercular treatment course is at the minimum about 6 months, and this will obviously be dealt with by the pulmonologist or the tuberculosis specialist. We can put her on withdrawal bleeds to maintain the growth of the endometrium, which would probably be cyclical HRT, to ensure that she has as much endometrial proliferation and development as possible. Once she has completed her anti-tubercular treatment, then we would probably advise the cavity to be reassessed. And as Dr. Shweta Mittal has said, that this has to be done by an expert who's an expert hysteroscopic surgeon to assess how the cavity has reformed. But overall, I think the prognosis in this patient is poor.
Okay,
Thank
so yes, because it is Esserman grade 4, and you can see here the very thick adhesions, and you can see even the caseous material. Now, what is your endpoint, Dr. Parul? I welcome you. He has joined. Like in this case, though
I
the
would add
prognosis
few
is very
things.
poor. Yeah.
Dr. Kuldeep, I would add few things to what Madam said.
Yeah.
That by and large, we now avoid putting an interposition like IUCD. But if at all we want to keep anything, a small balloon can be kept to keep both the space open, or rather endometrium not touching both falls.
Okay.
We should use that gel, what is it? Hydroxy, that gel is hyaluronic acid.
I think it is called a hyalogel.
Yes,
Hyalogel.
in India, it is not yet available, but Middle East it is, and we can procure that from there. And of course, second look, hysteroscopy within 6 weeks would be right, because flimsy adhesions, if they are there, only with the scope we can break those. So we do not wait.
Yeah. Dr. Ava, such cases, are you putting any barrier?
No,
and
I'm not
efficacy
putting
or
in
how?
any barrier. I
Okay.
tried putting in a balloon, but it was so painful post-operatively that I had to take it out immediately. And this was maybe 10, 15 years ago. Now I don't put any barrier. this patient will really have a poor prognosis for regeneration of the endometrium. And let us hope that multiple hysteroscopies and adhesiolysis might be able to give us some results. Otherwise,
yeah, even I previously I was using again 10-15 years back, but now but I am doing and I don't know the other people, but I am using estradiol valerate for 4 to 6 weeks continuously in these patients, and following it up with the subsequent scans to look at the regularity of endometrium as well as the blood flow. So
so
that is
since
how
Mhm.
these patients they need to be followed post operatively. Any other
I want to add on
solution?
one
Yeah,
thing,
yeah.
that this adhesiolysis is best done on the second, third, or fourth day of the periods, when already a follicular selection may not have happened inside her. And I start estradiol right from then. But then if you are giving 2 milligrams 3 times a day orally, it is a lot of estrogen going to her liver. So I prefer to use it vaginally. The same Progenova which we give orally, I prefer to use it vaginally so that liver pass can be prevented. And if we need to supplement her with more estrogen, then I can give her 3 applications of the estradiol gel, which is available at the
Yes,
same time.
yes. So
So
now we are having
4 weeks
actually the
is the
gel.
usual.
Yes,
And
transdermal gel. Yes.
the whole aim is to prevent her ovulation, because once if she ovulates and you are late in starting estradiol, then progesterone comes into circulation and the proliferative activity stops. The secretory activity causes remodeling and everything. So the growth of the endometrium will not happen if she is ovulated. Hence, the best is to start this even before the hysteroscopy, so that there is so much estrogen that it goes to the pituitary, negatively feeds back the FSH, and there is no selection of follicle by the time you've done a hysteroscopy, and continue it then for 4 weeks.
Sorry, may I just interrupt?
Yeah.
Yes.
Yeah,
So,
please.
so my question really is that you're speaking about HRT, and then what about, so at which point after the treatment of the tuberculosis do you start all of this, or will you go, my question really is that you
We've
are,
lost your voice.
No, this patient is already usually any intervention is not done before patient completes the
yes,
Yeah, this HRT is only to support the endometrial proliferation. That's all.
proliferation only. Yeah.
yes. So we can do that simultaneously with the use of the anti-tubercular treatment, but treatment to see how she responds to the HRT. But treatment itself will not be commenced till we know that we have had a good response.
Yeah, no, but I'll tell you, Rima, what we do is we would not do the hysteroscopy while she's still
Already.
actively
On
infected.
treatment.
So we have
Yeah.
to finish her ATT and then undertake her hysteroscopy.
Yeah.
Yeah.
So wait for the 6 months course to be complete and then begin all of this.
Yes,
I agree.
correct,
Totally.
correct. Yeah.
Absolutely.
So
No,
what about
I
the yes,
personally
Parul?
perform hysteroscopy simultaneously. Anti-tuberculosis treatment is going on after 6 to 8 weeks. After the 4-drug regimen is over, we switch to 3-drug. At that time, even if pregnancy occurs, it is not a problem.
Dr. Parul,
Yeah.
the
Yes.
first diagnosis was made on hysteroscopy, and the material which we got with that, whether it was histopathology or it was culture, and the ATT started. But then
Yes.
after that, we generally do not advise her to get pregnant or do not undertake anything till she's completed 6 months of the ATT.
No. After 2 months of continuous AKT, when it is a 4-drug regimen, we ask her to avoid pregnancy. But after 2 months, when she is switching to 3-drug regimen, she can become pregnant. There is no issue, and we have had such pregnancies,
So,
spontaneous pregnancy.
Dr. Parul, actually we are discussing about the intervention. The can become pregnant
Simultaneous,
while
because
on the treatment, but when you are planning a
Have
intervention,
30% of cavity only there.
yes.
And
6 months is
tubes
too
are
long.
blocked. Tubes
See,
are
6
blocked,
months
sir.
of AKT is too long and the fresh additions would be very thick then by that time. They will be organized.
Dr. Parul,
You want
already
to
her tubes
lyse
are
them when
blocked.
they are soft.
Dr. Parul, already her tubes are
Tubes are
blocked, her
blocked.
cavity is
Actually, we are
obliterated.
not planning any means. We are not, because she is a very severe case. So our aim is to make the
Restore her
cavity
cavity only.
receptive for the growing embryo. And this is what happened. You see 2 fresh cycles and 1 FET done. Good embryos transferred, including blastocyst. Patient had 1 biochemical pregnancy in second cycle. Always ET was 6.5 to 6.9. Only once in conception cycle it was 7.1. Now, what about the second look in such type of cases? Do you do second look in all cases or selectively? If selectively, then how? How you select your patient for second look hysteroscopy?
So I personally would do a second look in all such cases
All
which have
cases.
extensive additions, yes. And if she is planning for an IVF, it is worthwhile to put in a scope and then go for IVF.
Dr. Jayakanan, what is your practice of second look hysteroscopy in all cases of adenolysis or selective cases?
We do do the second look hysteroscopy in all cases of adhesiolysis, particularly, and we do use a balloon. We used to use the Cook balloon, but it was so difficult to get it out. So what we now use is the Foley's catheter 8 French, and we cut the tip and then insert in 3 or 4 days with the antibiotics, and not in the tuberculosis context, but what I'm saying, which in the UK context. And we do give the estrogen for 6 weeks. And then at the end of 6 weeks, once she has had a bleed, then we do a relook hysteroscope.
Can
Yes.
I ask you something, Dr. Khanna?
Yeah.
Instead of Foley's, can you use the ward? Because Foley will be hanging out quite a long catheter.
That should be possible, yeah. Word catheter is possible, but we've never tried. But the Foley's, the advantage is it is quite tiny, that the tube. And of course, it is an inconvenience for the patient. I know, but 4 days. But that the word is also coming out, isn't it? The word will also come out.
Yes, but it is a
not that
short
long.
one, so just
Yeah.
a little bit it may come.
Sure. Yeah.
Dr. Harish wants to say something. Harish?
Thank you. It's interesting actually. There is not much evidence out there for minimizing or reducing the risk of intrauterine adhesions following uterine surgery. Only evidence that is out there is for hyaluronic acid. There are 7 randomized controlled trials which have suggested that the risk of adhesion formation is less with the use of hyaluronic acid. And, I use that routinely in my practice here. And there is also another gel that's being available in the UK that contains carboxymethyl cellulose. Again, that's showing to be beneficial, or at least it's shown to be promising in terms of reducing the risk of intrauterine adhesions. For other interventions, I don't think there are good quality studies to say that they reduce the risk of intrauterine adhesions. And as Jay said, in my routine practice as well, I do offer second look hysteroscopy for, in fact, not just for intrauterine adhesiolysis, but also if I've resected a submucous fibroid, I do offer a second look hysteroscopy as well.
Okay, so I think these 2 cases, they have highlighted actually the importance of adhesiolysis and how post-operatively they can be managed. Of course, the practices are different. You have seen that all panelists, they are having their different approach, but the purpose is to get a better receptive endometrium after adhesiolysis, and need to see the efficacy, whatever you are using, whether you are using balloon or any gel or using only estrogen. It is better to compare your results with other literature and then decide. Mansi, how much time is available to me so I can move ahead?
Well, actually, the time for the whole of the webinar was till 6 o'clock. Bharti ma'am finished a bit too early,
Okay.
so I don't think time is a problem here.
Okay. So we move on to the third case. This is 34-year lady, married for last 4 years, has 6 centimeter endometrioma with infertility, received 1 cycle of induction and 1 cycle of intrauterine insemination. Now, how will you manage further medical, IUI, laparoscopy, IVF? It is open to anyone who can take up, and then we can discuss this case. Dr. Sweta, you will like to start?
So if I analyze, she's 34 years, and I presume when you say married since 4 years, possibly she's trying for 4 years or 3 years, has a fairly large endometrioma, and I don't think her tubes had been checked earlier before an IUI was performed, but I will not offer
Tubes were
her.
checked, they were patent.
They were patent. So now, it's a long duration of infertility. I want to check her ovarian reserve, and I want to see whether I'm not dealing with a coexistent male factor.
AMH,
If her,
AMH is 1.9.
yeah, and the third thing I want to see is that if the other ovary is also stuck behind the uterus or not on ultrasound. So my option for her, her AMH is 1.9, which is normal for her age.
Will you like to do any other testing apart from AMH to decide whether to go for surgery or for IVF?
So other than ultrasound, and I possibly decide on AMH and antral follicle counts. These are
Yes, so AFC is again very, very important when you are deciding the mode. So AFC is 6 on both sides.
and in my counseling, an early IVF will definitely come in, and she can maybe possibly choose between the two. Either it could be IVF or it could be a laparoscopic surgery with clearance, but with giving her the guided prognosis that 50% of patients with severe endometriosis will still end up in IVF. So I think these are the two options I will give her. Medical management, no, and IUI also with a 6 centimeter endometrioma, I would not advise
Dr.
to her.
Jaya Prakash, what is your opinion? How will you, given all the added points, you will go for surgery or IVF? You have to unmute. You have to unmute.
One thing is whether she has got any symptoms. Where is she in pain? She got significant pain affecting her quality of life?
She has come for infertility.
Just for infertility. So if she
Yes.
doesn't have a pain, I think in our practice, she is straight going for IVF. I'm saying about in terms of the fertility treatment, the laparoscopy that will have to make a decision depending on various other factors. But with regard to the IVF point of view, one is whether we can access the ovaries transvaginally.
Okay, so yeah, in your practice, you will go for directly for IVF. Dr. Sweta said laparoscopy, maybe early IVF. Dr. Abha, what is your take on this?
Well, I would consider straight away IVF in case both the ovaries are approachable and in case her antral follicles of the affected ovary are towards the vaginal side. I mean, we don't have to traverse endometrioma every time and the follicles don't lie behind it. I would go straight for IVF, but counsel her that she might need a laparoscopy after IVF because, if we do a laparoscopy first and remove the endometrioma of this size, there could be a significant reduction in the ovarian volume, the ovarian reserve, and the antral follicle count, which
Dr.
at
Rima?
the present moment looks all right in both ovaries.
Dr. Rima, what is your opinion?
I think I would agree with Jay and Dr. Abha that we would go for surgery first because she's 34. She's already been
They
trying.
are saying they will go for IVF.
Yes, I would go for IVF as well because she's 34, her ovaries are accessible. There's a lot of published information now to say that there's no benefit of doing surgery before IVF in these patients, and in fact, it might be detrimental. So if the ovaries are accessible, the follicles are accessible, and it is a 6 centimeter, but she's 34 years, I would definitely go for IVF first.
Dr. Parul, what is your take on this?
Well, I would go for the surgery first, especially in Indian context, where patients have to pay for IVF. That is a much more expensive proposition. And secondly, this is a unilateral endometrioma. So surgery makes more sense. If it had been bilateral, perhaps I would have also tried to avoid the surgery first. Of course, we can think, and if opposite ovary can show you good follicles, you can take them out and freeze them and then offer the surgery. But at 6 centimeter, I would go for surgery first.
Okay, so Dr. Abha, just summing up, what are the points which you take into consideration to decide whether this is for surgery and this is for IVF? Like
Okay.
one is, yeah, so
Okay, so if we find that the patient has a lot of pain, then surgery comes first. If our diagnosis is in doubt and we suspect any malignancy underlying a rapidly growing endometrioma, then surgery is first. If the reserve of the patient, ovarian reserve is low, then again, IVF should be the first option and not surgery. Similarly, bilaterality, like Dr. Parul said, if there is bilaterality, IVF should be first. So, surgery first is when there is too much pain, when there is a young patient with very good reserve, or there is diagnosis in doubt. These are the three important indications where I would want to go for surgery first.
like in this patient, you said you will go for IVF. So age is one factor which you are considering because she is borderline
Or she's already had a
borderline ovarian
surgery
reserve.
first. Ji?
She is borderline ovarian reserve.
Yeah, so I wouldn't want to go for a surgery with a unilateral endometrioma. I can get away with IVF, maybe freeze her embryos, and then if she wants to get rid of the cyst, she can go. Otherwise, pregnancy is also a cure of the cyst because 9 months of amenorrhea with a high progesterone status, even if she gets pregnant and she had no pain earlier, like you said, she can proceed without having the surgery for a pregnancy also.
So anyway, Dr. Parul has decided to go for surgery. So, Dr. Parul, what are the when you are going for surgery in this borderline patient, what is the tricks to preserve the ovarian follicles in this type of patient? Because that is one thing which we are worried. Dr. Ava is worried. Everybody is worried that this is the borderline case, and that's why they are going for IVF. You have decided for surgery, so what are the tricks actually of the trade in this case?
I think tricks are all very well known, nothing additional personally. But yes, since it is a unilateral, we are reasonably sure that the opposite ovary will be producing sufficient follicles, even if surgery impacts it. Of course, surgery does not always impact the ovarian reserve. We are always cautious about it, and we want to dissect. Cystectomy is, of course, the necessity. I do not go for puncture and drainage and then coagulation. So excision of the cyst, but proper playing is very vital. I personally do not use any saline injection or something which improves. In some hands, people feel that it improves the dissection. I have personally felt that I can find the planes and remove the cyst wall reasonably well. And other than that, nothing specific. If yes, simultaneously tubal issues are there, you can take care of that. If there is a hydrosalpinx, that also can be handled. Adhesiolysis is also performed. So all those additional things, if you notice them, you can take care of them. When you switch directly to IVF, we would not know what is happening inside the abdomen.
Dr. Nicholas, what is your take? We have asked, we have taken opinion from everyone. What is your practice? Like because this is a borderline case, means both can be offered to this patient. What you will do?
Thank you very much. Yes, I think because as you said, it's borderline, we would discuss both options of surgery or proceeding straight to IVF treatment. We would advise the patient that surgery to remove the endometriosis will give her small chances to have a baby. And there is a very good chance a few months or a year after she will still need IVF treatment. It would be an option, but in my experience in the UK setting, most patients would choose to proceed with IVF treatment. This is a lady who wants to have a baby. She's not bothered from pain. The seem to be an incidental finding related to IVF treatment. Now, if she would choose to have surgery, probably we would do a cystectomy, but it would be about the ovarian reserve. And I would like to ask the experts in the panel, has any of you been using alcohol sclerotherapy for these cases to get rid of the cyst and at the same time preserve the ovarian reserve?
Yeah, I think that is the one thing can be discussed here. So anyone is using sclerotherapy in such cases?
For pain, we might, but for infertility, I would be rather cautious. I do not know the long-term results of alcohol therapy because it is quite new for us.
Yeah, recently actually I was attending a session on endometriosis, and there the colleague from France he said that sclerotherapy is one thing which he will prefer over cystectomy. Of course, that is very debatable. That in all cases you will go for sclerotherapy, because sclerotherapy is having its disadvantages of spilling and other thing and complications. So I don't know. Means that is one thing which people are advocating now, to preserve the ovarian reserve. Sclerotherapy is advised. That is again new to me also, because in India we are not using sclerotherapy in many cases, in most of the cases. So what is the scenario in UK?
I think at the moment it's not widely used in the public sector due to regulation, due to the lack of evidence. It has been used in the private sector, but I have not used it myself. The evidence is encouraging. There is a good meta-analysis about it. So I was wondering if there is any experience, but I have no experience myself.
Okay. Dr. Abha, you are having any experience on sclerotherapy? Okay, so these are some of the guidelines. I will not go into the detail, but practically we have discussed this borderline case. See, age and ovarian reserve is one thing which you need to keep in mind. As far as the laparoscopy surgical management is concerned, there are the guidelines that surgery can be offered to patients who are having good reserve and having pain as a presentation. So I will not go into the details of this. Anyone will like to comment anything about whatever we have discussed, and then we close the panel. It has been a wonderful discussion. But last comment from all panelists, starting from Dr. Parul, then Nicholas, Dr. Rima, Dr. Abha, and Shweta.
Well, I joined much too late. I was spending a lot of time joining up. So I do not know the entire discussion. But otherwise, yes, case-based discussions are always very good to handle the situations. And you have a very varied panel. But I don't know, barring me, anyone is a career endoscopy surgeon, or most of them looks like to be fertility specialists.
Dr. Nicholas, what is your fertility is primarily a fertility person or endoscopy person?
Can I be both?
Yes, yes, that is what I am also.
We all are
Thank you.
both, but our primary focus may be different.
Yeah.
Yeah,
Dr.
I'm
Rima,
only a fertility enhancing endoscopic surgeon.
yes.
So I don't do hysterectomies, but I do myomas, adenomyomas, endometriosis, and pelvic clearance.
Because this beautiful debate was there, no, in fertility sterility recently. On one side, surgeon; on one side, the fertility person. That was, I mean, a vertical divide, you can say.
No, I think Dr. Parul, the time has come. We can coexist, and rather than debating, we should discuss how we can use two modality to increase the chances of conception. We should discuss in that way. That may be more fruitful, and the purpose of today's discussion was that only. Uh,
Fully agreed.
yeah, yeah.
I read somewhere the most important person in operating theater is the patient. So
Yeah.
that should be expanded to everything in medicine. That we have to focus on her needs, her expectations, and her desires.
Any comment from Dr. Rima? Will you like to say something? And Dr. Jayak Anand and Dr. Sweta.
So from all the three cases, what you just showed, my take home or my suggestion, number one, if it's a full blown tuberculosis and you have proven it, number one, a good tissue diagnosis is important. And then even our pulmonologists, they make the patients complete the ATT and then repeat an endometrial biopsy, to know whether she still has endometritis or no. And then we can go ahead, because with full blown COX, they will need, IVF. Number two, if they have dense adhesions, they may need more than one surgery. Some kind of adhesion barriers, which were discussed, which will be good. What is available in India and in UK are very different. And of course, a good surgeon, I think first surgery is the best surgery. So novice, I think in any of the three cases should not be attempting these surgeries. Only you, if you have had n number of experience in dealing with cases should be done. Regarding endometrioma, sometimes patients do not agree to IVF. Then they should know that yes, surgery is an option in the particular case you showed, with the prognosis, of course, because we have to document that it will reduce ovarian reserve and endometriosis in itself can reduce. So my take home is that yes, if we need to do surgery, it has to be the most ovarian preserving surgery as much as possible, with the best plane which you need to find and least energy source to be used in all the cases which you showed.
Yeah, thank you, Dr. Jayak Anand. Your comment, and then finally, who is left? Dr. Rima. Rima has already spoken.
No,
Yeah.
thank you. It was a wonderful experience and different cases. And I think we all have got different ways of dealing with it. And as you all mentioned, the patient is the most important thing. And if you're looking for evidences, particularly in the surgical field and infertility, because it depends on so many factors and it is difficult to control each and every factor. So to get absolutely a robust evidence, it is not easy in the surgery. And as you could see, I mean, we didn't discuss about the septum, but you know that the septum, the RCT, they have taken about 10 years to recruit 80 people in one of the kings of RCTs in Netherlands. So you could imagine that the surgery RCT is quite difficult to get robust evidence. So I think the patient is important, and then we will have to look at the pros and cons of the one management versus the other, and then let the patient choose. And of course, that we will have to guide them in terms of what the best for them to achieve. And as one of us mentioned about, their priority is to get the baby, and therefore we should focus on that depending on that situation.
Yeah, actually, I had a case of septum, very small septum. A lot of discussion could have gone on that. Then a small myoma impinging the cavity. Again, that was one case. But because of the time restraint, of course, we will continue this discussion maybe next time. So thank you very much, everyone. My panelists, they did really wonderful job, and they deserve a good round of applause. And thank you very much, Dr. Raj and Dr. Mansi, for providing this wonderful platform. Thank you very much.
Thank you, sir.
Thank you.
Thank you, Dr. Kuldeep.
Thank you. Thank you. Thank you for attending this wonderful platform. And I hope this will continue in coming year. And we will have more discussion on this really important subject, because everybody is having different practice, but finally fitting your practice along with the guidelines and all that, that is really a challenge. And you have to keep your patient's preference as well as patient well-being in mind when you are deciding about the surgery or ART. Thank you.
So thank you, the all the panelists for sending out such a strong and clear take-home messages, and for demystifying and simplifying these complex clinical scenarios. It is indeed a pleasure for all the delegates and all the listeners to be able to witness this. And as we have reached the end of today's webinar, I would just like to say the end is not always truly the end. It can be the start of something new, and in our case, I would like to see this as an opportunity to more future collaborations that we can have with the IFS UK Forum. Before we end the session, I would like to thank the IFS president, Dr. Pankaj Talwar, sir, who's always helpful and who's giving us this opportunity, wonderful opportunity to be able to conduct these webinars with such ease. It will not be complete if I don't thank Dr. Raj Mathur, the Secretary of IFS UK Forum, for giving us the opportunity to collaborate with him, and also Dr. Harish Bhandari, who has been very helpful and who has been essential in bringing about this webinar. It feels completely it's incomplete if I don't mention Dr. Jayant Mehta, sir, the patron of IFS UK Forum, who has been an integral part of IFS since the starting. He's been guiding us, the society, as well as he's been guiding me personally. So I am extremely thankful to him for his contributions. I am also extremely thankful to Dr. Uma Gordon, madam, for accepting my invitation, and it really meant a lot. Your inputs were very invaluable, ma'am. I would also like to thank my entire SIG endoscopy team, my seniors, Dr. Kuldeep Jain sir, Parul sir, and Desh Deepak sir. Together we make an excellent team, and this is how we move forward. And also, I would like to thank the speakers, my esteemed faculty members, the chairpersons, the panelists, without whom, I mean, they have added such value to this webinar, giving us very useful tips. And at last, I would like to thank the tech team who have made this whole process a lot easier for us and enjoyable also. So, thank you all. Hoping to see you all soon again. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Thank you.